Hello, everyone, and welcome back to the BackTable Podcast, your source for all things urology. You can find all previous episodes of our podcast on iTunes, Spotify, and at BackTable.com. This is Aditya Bagrodia as your host this week, and I'm very excited to introduce our guest today, Ganesh Palapattu from the University of Michigan Department of Urology. Welcome to the show, Ganesh. How are you doing today?
I'm great, Aditya. Good to see you, my friend.
All right, Ganesh. So from the outside looking in, when I think about Michigan urology today, that's kind of like the pinnacle. There's so many amazing things going on.
Thank you.
Really fleshed out across the whole gamut of urology from A to Z. And I think in no small part that can be attributed to your leadership and your journey. And today we're going to talk about the role of a surgeon scientist and maybe take a walk down memory lane and how you kind of got to where you are today. So perhaps we could just kick off with, what does a surgeon scientist even mean to you, Ganesh?
Yeah, that's a great question. It's got several different definitions, as you might imagine. Physician scientists who are surgeons or surgeon scientists, as you say, necessarily have to devote a significant amount of time to clinical work, more so than, say, our internal medicine colleagues or our non-procedural colleagues, mostly because what we do is a physical skill, as you know, and has to be practiced and done over and over again to be maintained. And so surgeon scientists, I would say, are those individuals who devote a significant amount of time not only to clinical work, but also to scholarship and research in some way. And that can be research of any kind, from health services, implementation science, trials, laboratory science, translational science, policy work. It could really just spans the gamut. And I would say that, in my view at least, it just identifies an individual who has scholarship going deep in some particular area of investigation that's interesting to them in a way that's beyond just their clinical work. And the complement of time devoted to that can be variable.
Yeah, and I think that's an important part that we'll kind of talk about. Maybe, if you don't mind sharing the evolution in terms of the push and pull of scholarship, scholarly activity, and clinical work, even over the course of your career.
Oh, it's constant tug of war, as you might imagine. I'll briefly kind of tell you my journey, and I can tell a little bit about that, if that's okay. So I went to the University of Texas in Austin, Longhorn, grew up actually in Houston for most of my younger life. And then I went to Baylor College of Medicine for medical school. And at that time at Baylor, someone I think many of your listeners know well, as you do, is Peter Scardino. Peter was the chair of urology at Baylor in the mid-90s when I was there. And Baylor was the recipient of the first prostate spore, Baylor and Johns Hopkins, but I think Baylor had the first one. And it was an exciting time at Baylor at that time. It was my first view that someone who sees patients and who's a surgeon could actually have a lab. And they had a number of faculty who did laboratory work at that time at Baylor. Dr. Scardino himself, while not actively involved in laboratory research himself, was very much a proponent of this sort of thing, and that urologic science should be done by scientists, but also by surgeons who know the questions to ask and could also contribute in a very meaningful way. So I say Peter, in many ways, is a mentor to me, as he is to, I think, many of your listeners. And I would say if there's one person who is probably the most responsible for me going into urology, it's Peter Scardino. And so I think being around that was my first introduction to what it could be. I took a year off in medical school to work in a lab, worked in a pathology lab. Marty Matsuk, who's now the chair of pathology at Baylor, was my lab PI. He had just started his own lab. And while it had nothing to do with urologic research, really, when I told Peter Scardino when I was a third-year minister, I was taking a year off to do this, his reaction was, "That's awesome. Tell me about it," rather than, "That seems silly. Why would you do that? Why don't you do something more surgically related?" Or, he could have been more negative or cynical, but he wasn't. And so that was also very important, and I think a later life lesson to me of being around positive people that can impact you in a number of very positive ways. So then I did my urology training at UCLA up the road from you. Again, being around there with a lot of surgeon scientists, physician scientists. UCLA has a prostate spore as well. Got one while I was a resident there. And Dr. DeCarney, the chair at that time, John was very much a proponent of science. And Rob Ryder and Mark Litwin, among many others, Ari Beldergren, very impactful to me, as seeing role models, Jake Rafer, seeing role models of what a physician scientist could be. I did my laboratory oncology fellowship at Johns Hopkins, and it was all laboratory based. I mean, I did almost zero clinical work there. And I worked in Bill Nelson's lab. Bill is now the director of the Cancer Center at Johns Hopkins, and he's a medical oncologist. And it was a great formative experience for me, being around not only folks at the Brady, but the entire community there, scientific community, how open they were, how welcoming they were, how there was, any question could be asked, and it was not ridiculed. It was like, wow, that seems really interesting. Let's try that. Almost maybe too easily. But it was a great experience for me. In my first job as a physician scientist was the University of Rochester with Ed Messing for about 3.5 years. And I came back down to Houston Methodist Hospital with Tim Boone when he had just separated, when they just sort of moved from Baylor. And I was there. My lab was at Baylor, but my clinical practice was Houston Methodist. And I came to Michigan about 12 years ago to be the Chief of Urologic Oncology with Dr. Todd Morgan, who's been on your program before. Another exceptional physician scientist. Man, he is something else. But Todd is when I first came here. So I've still maintained a lab. You might imagine my chance to really be involved in that lab work has really diminished given all the other stuff that I do now. But I mean, that's basically been my journey. And I think, physician scientists and surgeon scientists are extraordinarily important to the field. But, Aditya, I mean, I'm curious to hear what your take is on this. But I mean, it's difficult to do for a lot of reasons. And, let's just be honest, money is the primary reason why it's challenging. Money for the department, for the health system, for the medical school, and of course, even for the surgeon. We are primary revenue generators for health systems. And when you have surgeons who don't operate, it can be a financial liability for both, the department and the health system. So finding a microenvironment that can support this is a challenge, and then having enough of a critical mass of other role models and collaborators who understand what you do and understand why you do it, as well as why you may not be able to attend a research meeting because you have someone in the emergency room that you need to see, even though it's not your month on service, because you're always on service. Having those like-minded people around you is important, and I think having the leadership in a department that supplies and supports and cultivates and catalyzes scientific curiosity, risk-taking, and your own interests is very, very important. But I mean, it's far from perfect. The constant tug of war is there between time, money, interests, and really a broader thing, which if you want to talk about, I'd be happy to, is what I call faculty fulfillment, which to me is I'm constantly thinking about for all of our folks here.
Yeah, I really appreciate that. And a couple of things stand out to me. I mean, one is the environment. I think any of us doing anything, we're always kind of wondering what this looks like in a different environment without support. It sounds like you've had the good fortune, and I do believe that fortune favors the prepared, to be in places where surgeon scientists were recognized, were promoted, were supported. And I've certainly benefited from that early on as a resident. Was in a department where, we had PhDs and they were kind of integrated. During fellowship, spent some time in a lab with Dave Solid, Go Beyer, Darren Feldman. That was amazing. And when I came back for my first job at UT Southwestern, I had tremendous support from the department. Hey, let's see how this goes. And the one thing that I think is even more challenging now is the breakneck speed of progress, to kind of just stay up and feel confident that I have a broad and deep enough grasp of whatever it is I'm interested in to actually study this properly, to quote unquote compete with people who do this as a full-time profession. So maybe I'll just have you comment on that, Ganesh.
Yeah, definitely very much of a challenge, right? Particularly those of us who do translational science. We are competing, as you say, with individuals who are full-time PhDs who do lab work all day, every day, as well as our internal medicine or our medical oncology or, non-procedural colleagues who are on service 1 month a year, and 11 months of the year they're in the lab writing and doing, other experimental work. It's a big, big challenge. And as you say, I think it's important. I was very lucky to be around these environments at Baylor, UCLA, and at Johns Hopkins. I didn't mention it, but I should. Dr. Walsh, obviously visionary, and I think in many ways created the archetype for the surgeon scientist in urology. And of course, Don Coffey, and I'm happy to tell you a Don Coffey story before we finish here. That's, to me, emblematic of why I am still doing what I'm doing and why the fires just continue to get stoked by us here at Michigan for physician scientists. But I would say that as a surgeon scientist, you can't do everything. And, what we do as surgeons and as clinicians who do procedures, one thing is for certain is if you're operating, you have to operate. And you have to maintain that clinical skill. And there's that certain intimacy with patients. I mean, personally with patients, that we have that connection with them that I dare say non-proceduralists don't have. And we feel responsible for both the good things and the bad things that happen to them in a way that I think non-proceduralists don't. And because of that, our time with our patients, it takes us away from research work, rightfully so, when need be. And I think all of these things, particularly for surgeons who operate, because there's many surgeons who don't operate anymore. So when I'm talking about physicians, surgeons, scientists, as you say, I'm talking about clinically active surgeons who are also writing grants and, seeing patients, et cetera. But, team science is critical. Finding collaborators who value what you do as a partner, not just a tissue procurer, but one who can contribute scientific ideas and execute components of the laboratory work or the research work that is important is necessary and important. But these days, that can be hard to find. A basic scientist who values a surgeon scientist for what he or she or they can bring to the table, because they could say, I just go to pathology and get the specimens. Why do I need you? Or I could get, So they do need us, turns out, and I think we have to learn to be able to play well with others. And I'd say a lot of my laboratory training, scientific training, was really also built around learning how to collaborate, learning what value I could potentially bring to scientific questions, and improving my lexicon, my vocabulary to speaking science with scientists, so they might be able to take you somewhat credibly, versus just the surgeon who wants to be the last author on the paper because I gave you all my specimens. I think we have to be open-minded and engage in a scientifically curious and open way, and find those collaborators who are willing and eager to participate in team science.
Yeah, I love that. And obviously this is a podcast. Nobody can see my air quotes when I said compete, but I couldn't agree more. It's a team sport. And I think, building those teams, empowering those teams, being in an environment where you don't feel silly or exposed, asking questions that may be a foregone conclusion to somebody who's, pursued a PhD or something along those lines. You kind of talked about, I think, the intimacy of treating disease, quote unquote, having your hands in there. And maybe I'd ask you to just share some examples of how your science has impacted your clinical practice, and how your clinical practice has nearly certainly led to questions that inform your science.
Yeah, absolutely. I mean, I think, at least from my perspective, these days I see mostly prostate and I see some kidney cancer, but my earlier days I saw everything in the oncology space. But as you know well, as we're seeing patients in front of us in clinic, where it turns out life is not an algorithm, a flow diagram, and there's plenty of areas of gray. And something that I tell all of our trainees, one of my favorite aphorisms is that, we treat patients, not diseases. And we need to understand the context in which the patient is. And sometimes the book might say this or that, it's far from clear for the patient in front of us. So for me, what's informed me a lot of my early work was really to try to understand, why are some prostate cancers bad? And whom can we watch? And whom is it safe to watch? And whom is it likely to become worse in the future? How can we best detect the disease without putting someone through the medieval torture of a peritoneal biopsy if we don't have to? How best can we treat a patient to limit morbidity, obviously, the side effects of the different treatment options. So, treatment selection, patient selection, risk stratification, I mean, that's a very proximate clinical problem, as we see in the space where we live in as urologists, urologic oncologists. And I think that area of science is still, wide open. And I think that's an area that a lot of pure scientists would have zero insight in, as they don't see patients. They don't really necessarily understand those problems. And that's been, I think, a key to our success. I mean, here and at many other places, we have Arul Chennai. Dr. Chennai is probably one of the most successful cancer scientists in the world, certainly in the area of prostate cancer. Just a tremendous individual. And he, while a pathologist by training and doesn't do any clinical work, he fully understands the importance of science in the very early stages, like we do in diagnosis and risk stratification, as in addition to, of course, the very late stages as well. And I think that he's been an important component to our prostate cancer translational section. An individual like that who doesn't need us, but chooses to engage and chooses to allow us, permit us to kind of work together. We supply samples, we supply scientific insight, we participate in preclinical studies with his lab. But, here's a man who, has enormous discoveries already, might be might win a Nobel Prize at some point. But here's a guy who gets it, right, and gets the importance of team science. And I'm grateful to Arul. I mean, without him and his support, our prostate cancer program would not be what it is. And, over the years, our program has spawned a number of leaders. Ken Pienta, Marty Sanda, Mark Rubin, all came from Michigan at one time of their career. So it really does take a village in this sort of way. And as you said earlier, I mean, for urologists and the young folks who are listening, I used to keep a little notebook, or back when we had notebooks, but a little thing my lab coat I wrote down a bunch of questions my first 6 months to a year in clinic about why do we do this, why do we do that, and when you're seeing patients in your own practice, that might spur some kind of research, right? And why does someone with locally with intermediate risk prostate cancer progress in 2 years, and another almost identical patient did not? I mean, clearly under the microscope they look the same, but they're not. What's different, right? So how can we figure that out so we can better treat the ones who need it and avoid treating the ones who don't need to be treated? So those sorts of things have definitely informed my practice and continue to inform my practice to this day and our research enterprise.
I really appreciate that. My area of basic and translational work is in testicular, and the pressing questions in testicular cancer. How do we safely avoid surgery? How do we select the patients better for surgery? And I would venture to say that nobody kind of experiences that or understands that like a urologic oncologist. And I totally can get that. When I look at the faculty at Michigan, both current and previous, it's tremendous. And actually, another Ganesh who I really admire is Ganesh Raj, and he has this quote that if it's a hobby, it's the first thing to go. I'm not sure if he created that or not, but I believe it. And I think sometimes research is like that, where if this is not something that's truly valued, given the time that it deserves, it's not fair to the person doing the research, and it's not really fair to the research. So maybe can you talk a little bit about how nuts and bolts this is structured, funded, prioritized, any given person?
The special sauce, huh?
Well, the special sauce also, I also am co-fellows with one of my, and a dear friend, Sam Kaffenberger. And I'm just guessing that Sam's just never going to be happy unless he's in the OR for like 16 hours a day. So, it's not cookie cutter. I don't think. People have strengths, etc. But in general, maybe just broadly, what is required, in your opinion, minimum in terms of being successful?
I think a couple of things you just said there are important. I mean, you got to play to your strengths. There is some selection bias, right? We actively recruit those faculty who we think will be successful here for the reasons that we think are important. Not everyone can do science and research, nor should they. We have about 30% of our faculty who are active in writing grants, like NIH grants, R01s, and these sorts of things. I should plug that we are the number one NIH-funded department in the country. There are 3 years now in a row. Most number of surgeons with R-level funding in the country, clinically active surgeons. And our science runs the gamut from health services research to translational science to trials, et cetera, as I mentioned earlier. The special sauce is a couple of things. And again, I would also be remiss if I didn't mention Jim Monty and David Bloom. I've been chair now for 5 years and 2 weeks. Certainly COVID has warped everyone's sense of time, but it's been 5 years and 2 weeks. We wouldn't be in this position without Jim Monty's leadership, really setting the stage for our department in 1997 when he became chair, and really creating that proper atmosphere and culture that allowed this sort of area to really thrive and grow. It was because of Jim's foresight that the area of health services research in urology at Michigan blossomed. As he decided he saw this as something that was important and invested time and money and personnel to really get that going. David Bloom, additionally, when he took over, just built upon that, doubled down on that investment in HSR, and recruited people like me and Todd Morgan and Simpa Salami, Gold Cystoscope Award winner this year from the AUA, so very well-funded, highly successful surgeon scientist. So those individuals have really, really kind of cultivated this place to what it is. If I were to kind of break it down for you, I would say a couple of things are very important. One is philanthropy. Philanthropy plays an enormous role in help subsidizing and supplementing scholarly work. And I'll tell you in a moment here what we do with some of the different philanthropic funds to help investigators get going. But philanthropy is very important. Another thing is that when you're in academic practice, in an academic environment, you're not in private practice. And so if you expect to make private practice money in an academic practice, that's just not going to happen. And I think we are very clear with faculty who we bring in that if money is your sole reason, and it's not for most people, but if money is a primary driver of your clinical work and your professional work, then Michigan is not the place for you. If you want to be paid well, but at the same time contribute to scholarly work, either your own or others, educational opportunities for your own or others, professional development, work in an environment where you work with your friends, you work with an environment where people will surround you on your worst day because you'll have those, and people who will celebrate your successes on your best day, which you will have those. It's culture. It comes down to something like that. And so if you are of that mind, then this could be a place for you. So understanding that from the get-go, I think, is also important. So, the high RVU producers, the relative value units, the high clinical producers of any department have to understand that they bring tremendous value to the patients that we serve, but that money, depending on how money flows, and each academic medical center is different, but depending on how that money flows, some of that will be used to subsidize people who are not doing high clinical RVU work. You can't pay surgeon scientists 50% less than you pay full-time clinicians. You cannot. To me, the value then is placed that you value them less, 50% less. Money is not the only way to value someone, but that's a message that we try not to send, that we don't send to our faculty. And I say that an important component of our success is that, through philanthropy and through the understanding and the culture here of how money flows and how we subsidize things. So we provide lots of benefits for people beyond just straight compensation, which I think provides this whole sort of fulfillment quotient that I mentioned earlier. But back to philanthropy. So we've been able to do some interesting things with philanthropy. One thing is I created this thing called the Catalyst Award. Catalyst Award is where we take annually philanthropic funds, and I ask faculty, just give me a one-page research proposal. This is really for younger, junior kind of faculty. One-page proposal, only one page, or 1.5, with a timeline, deliverables, but basically tell me what you want to do, why you want to do it. And if it's, and I anticipate wanting to fund almost all of them, we give them $100,000 or so for 1 year, no strings attached, other than you give me a report at the end of the year about what happened. I trust you. Go ahead, go. Make some mistakes, fail. That's okay. These are the things for you to kind of try. And this is on top of their, startup package that they might have. This is for like some high-risk, high-reward things, or to help them supplement them, that they're trying to push some work forward, just about to get a grant. The purpose of this award is really to help catalyze, younger investigators who want to take some chances. It's okay to fail. That's how you succeed, right? You have to learn from your failure, to take some chances, get involved in some of this work. And who knows, you might hit a home run. And we've had a number of successes. Jim Dupree, Chad Elimutal, Seth Upachaya in our department, Will Roberts, a number of Julia Lane, Courtney Strohr, all of whom have become funded from the NIH after some of this funding. That's been, I think, to hate to say the word, catalytic, because it's the speed with which we give it. It's like less than 2-3 weeks turnaround time, no strings attached. And I literally say, I trust you, go ahead. Here's the account, here's the money. And it's been highly successful. So that and providing biostatistical support and other sorts of things for faculty, and help promoting their work, both locally, regionally, and nationally, connecting them with other collaborators around the country that I might know, or senior faculty here might know, that might help them get their work move forward, also help them kind of mentor them, because we know we don't know everything, help sponsor them. Sponsorship is an important component of what we do. We're big cheerleaders here at Michigan. The Michigan Happy Hour at the SUO is intentional, right? So yet another piece of the special sauce. So ingredient, it is about creating this culture of collegiality, of community, of teamwork, and that we celebrate your successes with you, and that I think can be infectious.
Yeah, I think it's amazing, and there's so many kind of going through my mind. The culture creation element of it, and valuing the different aspects of a department, I think can be overstated. I reflect back when I was at UT Southwestern, which was a very special place to me. Suffice to say, everybody was salaried, and there were people that were just working at a frenetic pace clinically, and there were people involved in education and research and so forth. And everybody, I just felt like, was comfortable in their own skin. There wasn't a lot of back and forth of I'm subsidizing this or that, or here's my RVUs. People just worked hard and they celebrate each other. And I always thought that was fascinating. And I might ask you your opinion on this. Recently there was a JAMA Surgery article on kind of production-based versus salary-based compensation models on terms of burnout and productivity and so forth. We can kind of maybe jump into that a bit. I think, a lot of urology departments, I think, are highly successful, and they maybe have a higher access to some intramural funding, which I think is tremendous to launch a career. It certainly launched any translational efforts that I've done, but I think even bringing it one step closer and kind of getting rid of the red tape and the crap is amazing. I mean, I love this idea of a Catalyst Award. It's like, hey, we hired you as a partner. We liked you. We trust you. We want you to be happy. That makes us happy. Show us something reasonable, rock and roll. I think that's tremendous. Maybe I'll talk to Manoj and Chris about that as soon as I possibly can. So you've really, shared some amazing things in terms of resources, which I think are absolutely mandatory to kind of get this going. What about the time elements of it, Ganesh? Or does that kind of come in the Catalyst Awards with, your salary's X? Why don't you use half of that to, take a day or a couple of days? How do you kind of see a minimum time requirement, or is there even such a thing?
Yeah, I'd say, so time equals money. So none of the Catalyst Award funds are used to supplement salary, zero. It's all to pay for research and other people's salaries or reagents or statistical packages or analytics or something. And it kind of dovetails to your initial comment from this portion about salary versus, kind of productivity-based for surgical departments. Again, that sort of has to do with time as well. Every academic center is different in terms of how the money flows. And I think the first thing is to understand your own situation and place and how the money flows. But culturally speaking and philosophically speaking, we're an academic medical center, and our charge and our self-proclaimed or self-realized charge is to not only take care of patients, but to make discoveries of all kinds and to train the next generation of both community urologists as well as those doing academics of all kinds. It's different than being in private practice. And so that's why I think philosophically you can't, and I love what you said, what Klaus has done at UT Southwestern. I think Mayo Clinic has something very similar. That's great, where I think everyone has to feel valued, right? So the clinician working at 10 p.m. can't say, where's so-and-so? How come they're in the lab? How come they're getting paid so much? Not at all, because that person in the lab is working on the weekends too, also working nights, you just can't see it. And that person is bringing prestige and making discoveries and bringing renown to the department in other ways that are in many ways equally important. So I think both the leadership, both individually and collectively, have to state that about what is important and that we value these individuals of all kinds. And so back to time, we have a number of faculty who have protected time for scholarly work of some sort, of anywhere between 50% protected to slightly more if they have grants that help fund that. An incoming physician scientist, surgeon scientist for us usually is 50% clinical, 50% research. But we have other people who do academic work, significant academic work, who have less protected time. Again, time is important because it then dictates how much clinical work you do, that dictates how many RVUs you make, that dictates how much money you bring into the department, right? So we do things both individually and collectively, and we have somewhat of a hybrid. There's in terms of compensation with salary and, some incentives of all kinds. We also incentivize scholarly work in research, education, administration, and citizenship. I am, though, a believer in, I don't like micromanaging. If you have the right people, and something I didn't say earlier, but I think is important, is that most systems work if everyone's working hard. And if everyone trusts one another, you don't do many rules. We step out of bounds every now and then or whatever, and somebody's unhappy. That's just the way it goes. But in general, if you got the right people who trust one another, working hard, whether it be research, education, whatever they're doing, it's going to work out. But when you have folks who are misaligned with incentives or what they think is important to them doesn't work with the group, that's when you have this dissension and where you have some real challenges to sort of come about. So, we have an evaluation form for all faculty every year. I'm sure you guys do too. I purposely put on the front page of this a quote that is, I don't know who said it, but, not everything that's measured is matters. Not everything that matters is measured. To ensure that the message is, yes, there's some things we have to measure, And I realize it may have some value, but there are a lot of things that is hard to measure that still has tremendous value. And that all these faculty are members of our family, and our professional family. We see many of these as UP folks more than we do our own family, and that they have to know that we care about them, we love them, we trust them. And I think without that core connection, a lot of stuff gets forgiven. I mean, with it, a lot of stuff gets forgiven. A lot of people get benefit of the doubt. People are willing to work hard. People are willing to take the call of someone if they have an R01 deadline without any payback. They're happy to do it, volunteer to do it. I've never been in a place, Michigan, where if someone has something to do, if something comes up in life, people are volunteering to take your call. I mean, with no payback, or they just do it. I mean, it's an amazing group, our faculty, who genuinely care about each other, genuinely, I'd say, love each other, and, they do their best to support one another. Is it perfect? No. But I think it starts with the culture, which to me is rooted in caring, love. I do believe in that, for one another, and trust. Without that, there's nothing. So if you got that, then you don't need many rules, because people are kind of just, listen, we'll figure it out as we go. I think the more rules you got, I don't know. I feel like a lot of rules, to me, indicates an issue.
Yeah, I don't think it's just you, Ganesh. I mean, there's pretty good data out there that lack of autonomy is pretty much the biggest driver of burnout and professional dissatisfaction. And, I like to be given the benefit of the doubt that I can structure some discretionary time as I best see fit. I don't want to clock in when I come in at 4:30 in the morning to prove to somebody that I'm working hard. And if I need to watch my kid play basketball at 4 p.m. on a Friday, I don't need to justify that to somebody. I think these things that you touch upon are tremendous.
That's exactly right, Aditya. I think there are some medical schools that are, really have a much tighter control over faculty's calendars and want to know who's in clinic and who's not, and what their templates are. Within reason, okay, but without divulging too much of what's happening at the University of Michigan, I just say I'm not a micromanager, and we don't do that. We have, like you say, I trust that you're working hard, and if you got to go take extra days off, so be it. Whatever. I mean, I would assume it's a good reason. I don't need a reason, and so hopefully our dean's not listening to this later on. But I just say we don't do a lot of the things. Sometimes I'm micromanaging. I just like you said, autonomy. It's about trust. It's about love. It's about caring, and then with a team that's built around that, you can focus on what you're doing, and that everyone else is working hard, and you can do amazing things together.
So sometimes you hear, I don't think this is a conception, it's a fact, that the surgeon scientist is a dying breed. Maybe first, just your opinion on that.
It is a dying breed, no question about that. And the reason is because it's pure math and it's finances. Typically, NIH funding is not keeping up with inflation and is contracting to some degree. We are, as surgeons, as you mentioned earlier, competing with people who do this all day, every day. Finances for the health system at medical schools is getting tighter. We are revenue generators. We are value generators for the health system. And so when you have a surgeon making surgeons money, but he or she is not performing at a surgeon's level in terms of clinical revenue, that's a financial loss. So it's very challenging for most health systems to support surgeon scientists. Physician scientists, like non-proceduralistic, the value proposition financially is easier to swallow. But for a surgeon, not so. Especially if you pay that surgeon something equivalent to what they would be, what a surgeon in that department should be making if they're not research oriented, and if you're not, underpaying people considerably. So yeah, the answer is surgeon scientists are diminishing, particularly ones who do translational work. Now, there's been a recent interest, rightfully so, in more like health services research. Michigan obviously is a place for this, and I'll plug out my good friend Brent Hollenbeck, who's now at Mass General, MGB. But Brent, extraordinarily successful surgeon scientist. Brent was with us for somewhat 25 years or so, and became now chair at MGH. He, John Way, in our department, really built out HSR with David Miller, now president of our health system, really built out the health services group with Jim Monte's backing. And that is a field of science I think is very complementary to a surgeon's life. It can be much more so than, say, laboratory science, where the reagents are more constrained and you have cells and maybe some animals or whatever animal work, and an experiment that goes wrong that took you 3 months to set up in the lab is different than an experiment that doesn't go as well, analysis that didn't go so well in the computational world, where it can be more easily duplicated without the time loss. But health services research is another area that I think is blossoming. We're seeing a lot of interest from SUO applicants and junior faculty getting involved in HSR, both on the finance side, financial toxicity work, implementation side, and trials work, policy work. There's a ton left to do. And I think we just also have to reframe our minds about what topics and domains do physician scientists or surgeon scientists in urology study. It doesn't always have to be, bladder cancer cells in a dish and sprinkling something and see what happens. There are many ways to do science. There are many ways to contribute scholarly work and do original work. And again, Brent is just emblematic of that. Brent Vahakan Shahinian in our group now, who's a co-chief of our HSR group with Aruna Sarma, and everything that they've done is just incredible. And their substrate for science is clinical work. It's large data sets that we all are contributing to on a patient-to-patient basis. So I think in general, the finances are putting negative pressure on incentives for surgeons to do science as well as health systems to support surgeon scientists. There are areas of science that are less expensive and maybe more time conducive to a surgeon's life, like health services and related fields and disciplines. Still, our field needs everyone. Needs all hands on deck to kind of tackle all domains of science, but I dare say not every institution can support all types of science. Not every institution should support physician scientists because it doesn't make much sense. But I think we can all realize the importance of having people in our specialty, wherever they might be, being involved in this kind of work, because that's what moves this field forward. Because as we talked about earlier, we are the ones who know the questions to be asked, because we are seeing these patients every day in a way that people who don't have no idea. They're solving problems sometimes that no one cares about. There are science projects that doesn't really matter, but we know what's important to draw. Because we're looking these patients in their eyes, and we're feeling it when we see them afterwards, and we feel like, man, I wish something would have turned out better. I wish I had better tools. I wish I had better answers.
That's amazing. I was kind of thinking as you were sharing that so eloquently that, probably what this boils down to is identifying what drives you, because it doesn't have to be basic or translational. It could be quality improvement. It could be physician wellness. It could be care delivery. Cancer care delivery is one that's obviously like near and dear to our heart. And I think science, as it's kind of historically been conceived, is exactly what you're describing, in vitro, in vivo, petri dishes, profiling and so forth. But maybe it's, what healthcare looks like in 25 years. Maybe it's just making sure guideline-directed practice is being executed at scale. And my sense is that you spend some time with your faculty identifying what drives them and then helping them, turn that into real, substantial change.
That's right. It's, like you say, engaging with individual faculty to kind of get a sense for not only what domains of science or what methods they know, but like a deeper level of self-reflection about why are you doing this in the first place? And I'll tell you, part of me being chair now 5 years and 2 weeks into it is part of that process leading up to was a lot of self-reflection about, like, why do you really want to do this? Why go through the process? And the answer that I don't usually like to hear when other people tell me about stuff is that I like building things. I'm looking for a new challenge. I want to do something. With usually sentences that begin with I, this is all very, inward looking, and I dare say somewhat selfish. The answers that I personally kind of respond to a little bit more positively when I'm talking to individuals who are aspiring to these sorts of things is like individuals who are looking to make an impact, looking to help people. And usually behind that, there is a story behind why that individual is doing it. Usually very personal, about a family member or themselves or someone they care about who was affected in something, some way that they saw that they couldn't prevent or that they couldn't do anything about, or they saw it was a positive thing. They want to do the same thing. And so understanding everyone has that sort of self-realization that, that if you would call it your why, that kind of the business parlance. But that's important. I think people understand what it is, why they're doing what they're doing. I told you earlier, I'll tell you a Don Coffey story. Let me tell you a Don Coffey story right now, because this dovetails very nicely to what you brought up. So when I was a fellow, a laboratory research fellow at Johns Hopkins, when Dr. Walsh was the chair, as I told you, I was with Bill Nelson in the lab. And at that time, there were I'm sure a lot of external visitors from other countries who kind of come and visit, and both for the clinical conference and the research conference. So on the Grand Rounds Day, I was sitting there like everyone else, And then right afterwards, there was going to be a research conference, and there was a research conference. And so we had some visiting faculty from Korea, I think, who were visiting at that time. And after the science conference was finished, Dr. Coffey was there, and he was there. People were milling about. I was just hanging around doing nothing or looking for an extra croissant or bagel or something. And then one of the Korean urologists, senior urologists there, asked Dr. Coffey, you're so obviously an amazing individual, made some tremendous impact in science. You trained so many people. This conference starts at 7 a.m. Well, why are you still here? He was nearing retirement, wasn't retired yet, but nearing retirement. Like, why are you here? And Dr. Coffey said, I may not cure cancer. But then he looked at me and said, but he might. That's why I come, right? And I thought, holy smokes. I looked behind me and said, are you serious? I got something in my mouth. Are you looking at me? But I realized, of course, it wasn't me. And as an individual, it's the young people, right? That was an enormously impactful kind of experience for me to realize that someone like him does what he does still at that, senior level of his career when he could do anything he wanted to do. But he was constantly stoking the fire. And then that stoking the fire was important to him because that's how discoveries get made. That's how the next generation gets inspired. And, Aditya, that's why I'm here today. The first part of my career where I was failing a lot, and I could have told you all of the times I've failed, which would take too long for this podcast. All of the numerous grants I wrote that got, not discussed and triaged. Oh my God, like 6 probably before anything even got reviewed. But why did I continue? Why did I keep trying? It wasn't a hobby, as you said, from Ganesh Raj. It was something I wanted to do. But the passion and the urgency for me to try was I didn't want to let Don Coffey down. I didn't want to, it's like he, again, not just see me as an individual, but young people, we as a generation had this sort of responsibility to do something. I need to do something. I'd be wasting it. I'd be wasting that legacy. I'd be wasting that connection. I'd be wasting that faith, that he had. And so what we try to do here, I hope, in some small ways to rekindle that same spirit with our trainees, with our junior faculty, with people that we interact with, the SEO happy hour. We have a Sufu happy hour. We have everywhere that young people are critical. They are the future, but they have to be supported and given opportunities to be successful. And we have to be role models and then let them go. Let them do it.
It's almost uncanny, Ganesh. My show notes, the last thing I had on there was what advice would you give to medical students or residents interested in following a surgeon scientist pathway or your footsteps? And you kind of captured that quite nicely. Well, this has been amazing. It's been inspiring to me, Ganesh. And I also, we didn't really get into the details. There's been so many elements of your career, collaborative team science with a lot of my friends and colleagues when you're in Texas and bladder.
Oh, yeah.
Shifting to...
Yair and I went to college and med school together. I don't know if he told you that. So I've known Yair for almost 30 years.
I would love to hear about his personal and professional evolution as well as one of my
That's right.
dear friends and mentors. This podcast is about the evolving role of a surgeon scientist. And I think, that evolving element, looking at your career from collaborative team science to translational science to basic science to administration, it's an evolution. Absolutely. And maybe as we kind of come across, almost an hour here, what are some of your parting thoughts for the listenership?
I have many, I guess, but I think self-reflection is important, as I mentioned earlier, to understand, and it doesn't necessarily have to be shared, but you ought to know the reason why you're doing what you're doing, because I think you'll find that in your life that the professional things that you choose to do that are counter to the reason why you are actually doing what you're doing, they provide sources of, discontent and dissonance that can be disposed of if you just realize, listen, hey, if you know what you're doing and why you're doing it, and you choosing then to do this or choosing something to do that, but it's not aligned with that, I think that's a source of real discontent a lot of times. Another is you can't do everything. You have to focus on things that are important to you, again, coming down to the reason why you're doing what you're doing. But there are also many more important things in life outside of urology, surprisingly, right? So understanding what those are, making time for those people who care about you, who you care about, ensuring that you maintain those friendships, because I'm sure for like most of us through medical school and residency, I've been to speak to people for like 10 years, except at, unfortunately, weddings and funerals. But make time for those people. Ultimately, it's a marathon, not a 100-yard dash. And it may not even be that. It may not even be a race. So be open to the, different things that kind of happen in your life that might take you in a different direction. I think these days, with social media in particular for the younger generation, the sense by some that other people's successes are your failures, that is absolutely not the case. That other people who are doing things and publishing this or getting these grants or being promoted in this is somehow a negative commentary on you, your self-perception that perhaps you're not doing that. That's absolutely not the case. It's truthful. Everyone has a different journey, and you have no idea the trials and tribulations those individuals did to kind of achieve what you are outwardly seeing them do. But I bet you have done enormously amazing things as well that may be beyond the purview of urologists that are more important. And, people at home, children, family, parents, there really is nothing more important than that. So I would say recognize that those things are extraordinarily important in your career, and they play an important part in your professional life and making time for those individuals that you probably have not had a chance to spend time with during your early career days and or certainly during your training. And lastly, I'd just say, keep up the fight. Urology in the field of medicine needs all of us. All of us are contributing in incredible ways. They're not all the same, and they're not all measured. And as I mentioned earlier, not everything that matters, and not everything that matters is measured. But know that you're doing a good job. Try to find your people meaning people who think like you, people who are positive. And I said it earlier, I attribute also a lot of my career about being around positive people, from Peter Scardino, Gene Carlton, Jean DeCurnian, Mark Litwin, Rob Ryder, Pat Walsh, Bill Nelson, of course, Don Coffey. These people, changed my life. Tim Boone changed my life. And they were enormously positive people and supported me when they didn't have to. And I'd say they're all out there. Find them and stick with them and be that same person to someone else. And I think we'll find that we're all going to be the better for it.
Ganesh, amazing, and so well said. Well, I leave this conversation inspired. Absolutely. I hope the listenership finds some value and some nuggets within it. So thank you for your time, and look forward to seeing you at the AUA Michigan blowout
reception. Absolutely. Everyone's invited. If you're listening to this podcast, look for soon a broadcast about the location of it at AUA. Everyone is welcome. And Aditya, thank you, brother. I appreciate the time, and thank you for the opportunity to kind of share some of my thoughts with your listenership today.
It was a pleasure.